Diabetic eye disease describes a group of conditions which affect people with diabetes, many of which can threaten vision. There are three groups of conditions that we need to consider. Firstly, there is the ocular conditions which are actually associated with diabetes, such as cataract and diabetic retinopathy. Secondly, there is a group of conditions for which diabetes is a known risk factor, such as glaucoma. And thirdly, there is a group of ocular conditions where diabetes is a possible risk factor, such as vascular occlusions and corneal disease. People with diabetes may actively only seek an eye examination when they experience visual problems, and it is essential to consider the possibility of diabetes in all patients with unexplained change in refractive error, complaints of diplopia, cataract or retinopathy.
We're going to test your distance vision first.
Let us consider some of the likely presentations at the eye clinic. Fluctuating refractive errors. Patients with newly diagnosed diabetes and unstable blood sugar levels can experience changes in refractive power of between 3 to 4 diopters of far or nearsightedness. This is thought to be due to the effect of glucose products on the lens, resulting in temporary blurred vision. Reassuring the patient and educating them about good glycemic control is essential before prescribing any additional spectacle correction. Diplopia, or double vision, can arise from palsies of the cranial nerves. Diabetes is the cause of diplopia in 30% of people over 45 years and older who have developed acute extraocular muscle palsy. The underlying cause is thought to be microvascular damage to the cranial nerves. With good glucose control, people generally recover muscle function within 3 months. The most important vision-threatening diabetic eye diseases include cataract, glaucoma, and diabetic retinopathy, including diabetic macular edema. Other conditions, for example anterior ischemic optic neuropathy, can affect a small percentage of people with diabetes. It is essential that diabetes eye services closely monitor people with diabetes to identify vision-threatening diabetic eye disease early on and prevent blindness. Cataract. Patients with diabetes are 2 to 5 times more at risk of early cataract formation. It is estimated that up to 20% of all cataract operations are on people with diabetes. Posterior subcapsular cataract is a major cause of vision impairment in people with diabetes. The risk of developing this condition increases with increasing duration of disease and severity of hyperglycemia. The level of visual complaint should correspond to lens opacification. Comprehensive examination must always be undertaken to identify any underlying diabetic retinopathy in people with diabetes. Vision loss from cataract is reversible with surgery. However, it is important to be aware that pre-existing diabetic retinopathy may worsen after cataract surgery. When managing cataracts in people with diabetes, it is also important to consider endophthalmitis, a severe infection within the eye and a devastating post-operative complication. People with diabetes are at increased risk of developing endophthalmitis after eye surgery. Primary open-angle glaucoma involves a spectrum of disorders which are typified by characteristic changes on the optic nerve and visual field loss. A recent systematic review highlighted that people with diabetes have an increased risk of developing primary open-angle glaucoma. There is nearly double the risk of glaucoma in adults with diabetes. Screening for glaucoma is challenging. However, it is important to carry out the detailed eye examinations essential for early detection of glaucoma, as the disease remains asymptomatic until the late stages and often remains undetected by patients until fairly advanced. Neovascular glaucoma is a visually serious consequence of underlying systemic ocular disease. Inadequate blood supply leads to neovascularization of the iris or neovascularization of the lens for drainage in the eye. And this ultimately leads to increased pressure. Diabetes accounts for approximately 1/3 of cases of neovascular glaucoma. It occurs particularly in those who have proliferative diabetic retinopathy. The incidence of neovascular glaucoma in diabetes is further increased amongst those who have already undergone previous ocular surgery. Panretinal photocoagulation is the procedure of choice for managing neovascular glaucoma. Diabetic retinopathy, including diabetic macular edema and proliferative disease, is the most common complication of diabetes and the leading cause of visual loss. Systemic blood pressure has a profound effect on the onset and progression of diabetic retinopathy and should be checked in every individual at each visit to the eye services. Over 90% of visual loss in diabetic retinopathy can be prevented with adequate treatment. People with diabetes may not be aware that they have retinal changes, and therefore screening programs are essential for early detection of diabetic retinopathy. A workable classification system is essential to identify and characterize and grade the level of diabetic retinopathy found in screening programs. Grading the changes seen in diabetic retinopathy screening describes the clinical severity of the condition and can be used to predict the risk of vision loss and provide appropriate management guidelines. Various diabetic retinopathy classification systems are in use worldwide. The system presented here is the International Clinical Disease Severity Scale for diabetic retinopathy and diabetic macular edema. This classification is simple to use. It's primarily based on clinical examination and emphasises the severity of the clinical disease in the retina and specifically at the macula. The International Clinical Disease Severity Scale for diabetic retinopathy has 5 stages. Standard colour fundus photographs of each stage are available to compare with clinical findings. In stage 1, no apparent retinopathy, there are no diabetic fundus changes. In stage 2, which is mild non-proliferative diabetic retinopathy, a few microaneurysms are present. Stage 3 is called moderate non-proliferative diabetic retinopathy. Here we see the presence of microaneurysms, intraretinal hemorrhages, or venous beading, which is more than just microaneurysms but less severe non-proliferative diabetic retinopathy. Stage 4, severe non-proliferative diabetic retinopathy, is the most important stage to identify, as treatment at this stage can prevent vision loss. The 4-2-1 rule is sometimes used to help identify stage 4 disease. This is when any of the following signs are seen, but there are no signs of proliferative retinopathy. 1. More than 20 intraretinal hemorrhages in each of 4 quadrants. 2. Definite venous beading in 2 or more quadrants. And 3. Prominent intraretinal microvascular abnormality in 1 or more quadrants. Stage 5 is termed proliferative diabetic retinopathy. Retinopathy in this stage has progressed to neovascular changes affecting the iris, angle, optic disc or retina, with complications such as vitreous hemorrhage or retinal detachment. Laser treatment is needed urgently at this stage to preserve sight. The International Clinical Disease Severity Scale for diabetic macular edema. The grader notes whether macular edema is present or absent on clinical examination by noting the presence and distribution of exudates at the macula. If exudates are present, they can be further classified into mild, moderate or severe, depending on the relationship of the exudates to the fovea, as compared to standard colour fundus photographs. The ocular conditions where diabetes is a possible risk factor are vascular occlusions and corneal disease. Retinal vein occlusion is the first condition. The sign of retinal vein occlusion can mimic that seen in diabetic retinopathy. Therefore, when people with diabetes present with acute vision loss and signs of diabetic retinopathy in one eye, a retinal vein occlusion should be considered. Patients may require laser treatment to address the complications of neovascular glaucoma and macular edema. Retinal artery occlusion is the second type of vascular occlusion. Retinal artery emboli and occlusion have been shown in some studies to be more common in people with diabetes, although the evidence is not consistent. The prevalence of diabetes in patients with retinal artery occlusion has been reported to be as high as 20%. It may be that diabetes is only one of a range of cardiovascular risk factors for this group of conditions. Ocular surface disease. A variety of corneal abnormalities are seen in people with type 2 diabetes, such as dry eye syndrome, corneal erosion, persistent epithelial defects, and corneal ulcers. People with diabetes who wear contact lenses are at particular risk of developing epithelial damage. Treatment is generally with artificial tears, contact lenses and topical lubricants. In summary, diabetes has an impact on vision in many ways, and clinicians need to be aware of the range of presentations and suspect diabetes as an underlying cause. People with diabetes have not always shared the same favourable outcomes after cataract surgery as their non-diabetic counterparts, and appropriate surgical, laser and medical treatment has to be made available. Diabetic retinopathy requires early detection through a specific screening programme and the use of the International Classification System for grading and assessment of disease severity.